speaker is Dr. Gaurang Ramesh. He is a conventionally trained gastrosurgeon and further trained in functional medicine. He's the founder of Arka Integrated Healthcare. I had the opportunity to visit his center, and it's amazing to see how he has beautifully combined different tools, strategies, methodologies to offer a comprehensive holistic care to his patients. Today, he'll be speaking about GERD, whether it's about low stomach acid or high stomach acid. We often see people just popping up antacid pills. So is that the solution to GERD? We'll hear more from Dr. Gaurang. A very warm welcome, Dr. Gaurang. Over to you.
Thank you so much, Dr. Rohi, for the wonderful introduction. And thank you for giving me the opportunity to be presenting it with such an amazing panelist and, more importantly, very curious audience. And it's also my absolute honor and privilege to be sharing the stage with my teachers, Dr. Lenny, Dr. Milisha, and Dr. Preeti Nandasibal also. So I'll just share my screen. Can you see my screen?
Yes.
So today I'll be sharing with you a little bit about GERD pathophysiology and understanding how hypochlorhydria can cause GERD and how we can optimize the healing process to heal faster from GERD. So we use the word acidity very often, and we use it with gastritis and GERD. And most often, we are treated with the same drugs for both the problems. When we need to understand what is gastritis, it is the inflammation of the stomach lining. And GERD is when the content of the stomach comes up into the esophagus and causes problem. So acid gastroesophageal reflux disease is actually a symptom because of the wrong location of acid and not because of the acid itself. So most commonly we complain of heartburn. Behind the sternal bone, we have burning sensation, regurgitation, and sometimes you may experience difficulty in swallowing, chest pain, water breath sensation. And some people may not have anything to do with esophagus and stomach. They may just have cough, which is not going down since a long time, hoarseness of voice, and wheezing. So when we look at how our gastroenterology defines GERD, its symptoms or complications resulting from the effortless reflux of gastric content into the esophagus or beyond, into the oral cavity or to the lungs or the larynx. So we have a definition for GERD, but to actually diagnose GERD with a confirmation, it's very difficult because when we put a scope into the stomach or the esophagus and see, very few people actually have erosions. Only when you have erosive gastroesophageal esophagitis, we can see something physically and diagnose. They may end up with strictures or Barrett's metaplasia or cancer, or they end up with bleeding. But many people have just extraesophageal symptoms, which has no symptoms physically in the stomach and esophagus. And many people have non-erosive esophageal reflux disease, which is more common than erosive reflux disease, where they absolutely don't have any findings in the endoscopy. So when we do an endoscopy for 10 people, 7 people do not have any finding, but the symptoms is as much as people who have some finding in the endoscopy. So we are actually doing more endoscopies than we're supposed to do, but there are some red flags when we need to do endoscopies. So when your difficulty in swallowing is not, it's progressively increasing, you have unexplained weight loss, unexplained a loss of appetite, there is some signs of upper GI bleed like dark colored stools, there is unexplained loss in hemoglobin, anemia, the vomiting is not reducing, and in all patients above 65 years, when we need to have a surveillance for cancer, endoscopy is really important. So post-food, the frequency and severity of heartburn is not associated with the degree of damage in the esophagus. I've seen some patients who just come for a surveillance endoscopy or they're coming for a workup. They have moderate esophagitis. There is erosions in the esophagus, but they don't have symptoms. And some patients who have a lot of symptoms of reflux don't have any findings. So I would like to share with you all a patient's story who had an atypical reflux disease presentation. She was a 33-year-old who came with severe heartburn, difficulty in speaking, foreign sensation in the throat after breakfast. It was getting worse at night, and she was on all antacids, not getting down. She didn't have any hematemesis or coughing or postnasal drip, but she had bloating, epigastric burning, and discomfort after food. She had a traumatic childhood, lost both parents, had to make a living alone. She was on double dose of acid blocking medicines, pantoprazole, and she would take a prokinetic 3 times a day. She was a marketing executive, but as soon as she has breakfast, she could not talk. So she had to leave work, and she had no support emotionally and spiritually. Although she would not eat junk food, but very often she would eat easy to cook or ready-made food, which were very high in simple carbs. And she had a lot of sensitivities and could not tolerate many supplements. She was evaluated by many gastroenterologists, done endoscopy many times, which was all normal. 24-hour pH study was normal. Manometry, a motility study turned out to be normal, and H. pylori was negative. So when we see such cases where we cannot physically see anything, evaluations are all normal, GERD can be one of our biggest opponents. So with this patient, we understand that it's not just a mechanical or chemical cause. So GERD can be immunological, pathophysiology can have an immunological basis because inflammation can cause it. It can have psychological contribution. It can have neurological contribution mediated by the vagus nerve. So when we put our functional medicine hats on, we can see that even in the mechanical or anatomical causes for GERD, we see inflammation at the foundation. And when we have a lot of testing, we can do a urea breath test to look for active H. pylori infection. We can look at the pH monitoring in the esophagus and stomach. We can look at the pressures in the esophagus with the esophageal manometry and see if it's a motility disease. And of course, endoscopy we can do. But when we look at functional medicine and we want to understand the root cause, we can also do a comprehensive stool test where we understand if there is any SIBO or C4 contributing to GERD. We can also look at a 4-point salivary cortisol test where we see if the sympathetic system is overstimulated and vagus nerve is suppressed, and we can also evaluate the melatonin. So currently, what is our management for GERD? This is our current guidelines. It looks comprehensive, but it's a little unfortunate because all that it tells us is we need to do an endoscope and start people on antacid medicine. If they don't respond, increase the dose. And if they don't respond to that and there is no endoscopy finding, we call it functional disease. But we have seen continuously in our practice that 30 to 40% of the people don't respond to only acid blocking medicine. And these people end up staying with prokinetics and acid blocking medicines for a very long time. And if it is a motility disorder causing reflux, sometimes we cannot do an anti-reflux surgery. They will not respond to anti-reflux surgery also. So this is why we need to put our functional medicine hats on and look at the root cause. So we see inflammation at the foundation of GERD also, which can, like Dr. Preeti was explaining, it can lead to leaky esophagus and result in motility disorders. So when we see so many people not responding to acid blocking medicine, we need, and some patients we can see that acid blocking medicines can actually increase GERD. It may improve gastritis, it may reduce inflammation in the stomach, but it sometimes increases reflux. So we can see two basic mechanisms with which this might be contributing. One is bacterial overgrowth, which Dr. Preeti was telling, and maldigested carbohydrates and proteins causing increased intra-abdominal pressure. So these are the causes of decreased stomach acid in our body. The main cause which we see in the population now is because of the acid blocking medications itself. And the second highest cause is actually H. pylori infection. So this is a very old bacteria which has stayed with us during the evolution. It's very common, 50% of the population has H. pylori in the stomach, but it doesn't multiply unless the environment is ideal for it to multiply and start creating problem. So acid suppressing drugs can actually worsen H. pylori infection because they make environment more ideal for it to start proliferating. And we can also see reduced acid secretion when our parasympathetic nervous system, the vagus nervous system, is slightly suppressed because we're always under stress and our sympathetic nervous system is always worked up. And anything which can suppress the vagal nerve activity, like hypothyroidism, traumatic brain injury, brain neurodegeneration, seen especially in elderly population, can reduce vagus nerve activity, which can again reduce our acid secretion. We can also see reduced acid secretion in gut degeneration, in inflammatory bowel disease, sometimes in eosinophilic esophagitis or gastritis. All these patients have degeneration and their functions start reducing. So what exactly happens when the acid becomes less? So hydrochloric acid is the main enzyme which helps initial part of digestion. So in the stomach, it helps in breaking down the protein, breaking down complex carbohydrates, and it actually stimulates pancreatic enzyme release. And it also stimulates gallbladder contraction, and then the bile is released. So when hydrochloric acid reduces, we not only have reduction in breakdown of protein and carbohydrates in the stomach, but also reduced pancreatic secretion and bile availability. That leads to maldigestion. And when we eat something, we are actually getting the microbes from the environment into our stomach. And in the stomach, the acidic level environment and the pH is so low that most of it is killed and a sterile liquid then passes into the duodenum. When we reduce the HCl completely, we stop sterilizing the content in the stomach, and we are giving opportunity for the microbes from the environment to get into our duodenum. Of course, our microbiome is a wonderful Amazon forest by itself and it has its ecosystem. But then, like Dr. Preeti was explaining, the highest quantity of bacteria is in the colon, and from the stomach, it gradually starts increasing. But because this happens, we end up having small intestinal bacterial overgrowth, and that can lead to gas formation, and that can lead to reflux disease. So this bacterial imbalance and maldigestion together can disturb the environment in the intestines, and that increases the antigen exposure to the gastrointestinal immune system because of increased intestinal permeability. And when we alter the pH in the stomach, then we are altering the pH in the intestines also, which leads to decreased microbial diversity. So all this is leading to multiple nutritional deficiencies, iron, B12, folate, calcium, and zinc. It is causing bacterial overgrowth, weakening the immune system, and it's increasing our risk to develop chronic diseases. A great example for this was during COVID. We have seen multiple studies showing that when the patient was treated with PPIs or acid blocking drugs, 30 days previously, we have seen severe clinical outcomes of COVID-19 in the ICU. So we know, I'm not saying that acid blocking drugs are bad. Acid blocking drugs are actually a very powerful tool, and we have actually seen it help a lot of people. When I was in my post-graduation, we would hear our teachers and even my parents, when they were doing their post-graduation, would see every day during their night duty, they would see somebody with a hole in the esophagus, hole in the stomach, or hole in the duodenum because of acid peptic disease. And when I have studied my medicine, we have hardly seen such patients because PPIs will prevent people from having complications. But that doesn't mean that we should end up giving acid blocking drugs for a long time. When acid blocking drugs were introduced into the market, it was clearly stated that we should not be using for more than 4 weeks. But now we end up using for years together. So when we are reducing acid blocking drugs, we should not be very over enthusiastic and stop them right away, because we need to assess all the factors which could worsen the patient's condition. So acid blocking drugs is only working on the parietal cells and decreasing the HCl production, but it's not acting on the G cells which produce gastrin, and gastrin actually stimulates the parietal cells to produce hydrochloric acid. So when we use PPI for a long time, then gastrin gets accumulated in the stomach mucosa. And when we suddenly stop, it overstimulates and causes excessive gastritis. So we need to carefully wean it off to avoid this. And we should also be careful with people using it for more than 5 years and people who are using double dose of PPI. And we cannot reduce it right away in people with hiatal hernia because they have increased chances to develop esophagitis or esophageal cancer. We should be watchful if the stomach emptying time is normal. And we should also be careful if there is grade B esophagitis or higher. So it always has to be done under supervision, never done suddenly. And we should correct the pathophysiology before completely stopping it by supporting the stomach to heal, reversing gastroparesis. And we should, from every day, we should gradually reduce it to alternate day. And when we do that, and if you have any symptoms, you can take a H2 blocker called ranitidine or melatonin. And then with gentle acid suppression, we should add acid supplementation and then gradually wean it off. So what did I do in the 32-year-old female? So first, we call it a 5R approach in functional medicine. We remove what is causing problem, we replace the good enzymes, and then we re-inoculate good bacteria, repair the stomach lining and the esophageal lining, and then balance the body. So first, I removed high carbohydrate diet, simple sugars, because that feeds the small intestinal bacterial overgrowth and fungal overgrowth that can in turn contribute to GERD. And if there is an H. pylori infection, it's very important to correct it, because unless we remove H. pylori or reduce the load, it will not allow our stomach lining to heal. We can do it with botanical antimicrobials, or we can do it with pharmaceutical antibiotics. But although I have drastically reduced antibiotic use in my practice, for H. pylori, I still use it because it's a very strong bacteria, and it will not allow healing to happen unless it's properly reduced. We'll have to make some major dietary and lifestyle changes, and we'll have to change our eating patterns. So why does diet and lifestyle matter? Coffee, alcohol, chocolate, mint, fats, and carbohydrates will actually reduce the lower esophageal muscle tone, which can contribute to GERD. And large meals and carbonated drinks can actually increase transient lower esophageal sphincter relaxation, which can again contribute to reflux. And alcohol and fatty meals can reduce gastric motility, and the food stays in the stomach for a longer time, and then it contributes to GERD. And acidic foods like spicy food, citrus foods, and drinks can actually irritate the mucosa in the stomach. And when you have GERD, it can end up irritating the esophageal mucosa also. Eating late at night, not giving enough gap between your meal and sleeping can also increase gastric acid secretion. And large meals and carbonated drinks can contribute to gastric distension, and gastric distension then will eventually result in reflux. And you can also consider other factors like stopping milk, decreasing very salted foods, decreasing fried foods, avoiding soft drinks, and avoiding onions. So we should concentrate on increasing foods with a pH of greater than 5, like having fruits like papaya, melons, banana, avocado, having vegetables. There may be some vegetables which may be difficult to digest if we have low stomach acid, like beans, legumes, whole grains, and nightshade vegetables. So when we see inflammation has the foundation of GERD, we need to concentrate on reducing the inflammation. Antioxidant-rich food has to be added. Essential fatty acids is required. Good quality, easily digestible protein. And we need to make it as simple as possible to digest by chewing properly. Physical activity has a little controversial relationship with GERD. All the activities where you are doing stoop posture, like bicycle riding, weightlifting, swimming, and even surfing, can actually increase GERD shortly after you do the activity. But physical activity is absolutely necessary. Regular mild aerobic exercise can improve GERD, especially after about 10 minutes after you eat. Walking for 5-10 minutes will help a lot. The second step is to restore the lining of the gut, help the lining of the gut improve by giving the enough nutrients it requires, and then the gut will repair itself. So we can use raft forming agents like alginate. Licorice is a herb which can help in supporting the gut lining. Slippery elm, aloe vera, zinc carnosine. Zinc carnosine actually helps us form the protective layer in the gut. And of course, antioxidants like curcumin, vitamin E, and quercetin have shown to reduce reduce oxidative stress by increasing antioxidants. And we need to also look at reducing the anatomical problems like hiatal hernia. So alginate especially precipitates in the gastric acid and forms a gel, and the bicarbonate converts to carbon dioxide, which then gets trapped in the gel, and it has a neutral floating barrier. So we can use that instead while we taper off acid blocking drugs. Melatonin is something I learned from Dr. Lenny, is 400 times more melatonin is synthesized in our gut than our pineal glands. And after eating, we have more melatonin in the mucosa of the gut. And melatonin actually reduces the inflammation in the esophageal and stomach lining, and it actually reduces gastrin production, which in turn reduces acid production. So I use melatonin when I'm tapering off PPIs and also in gastritis patients. So another important thing is to make sure that the delayed gastric emptying is not there. And some of the natural things which I use in my practice is ginger, tryptophan, magnesium, vitamin D, Triphala, probiotics, especially Lactobacillus reuteri and Bifidobacter species. And we usually have a naturopathy practitioner in our practice who does acupuncture also. And we always teach our patients to do deep breathing and stress reductions. Acupuncture, although in pure science, we are not properly understood the mechanism. When we look at the results of acupuncture, we have seen increased gastric peristalsis and accelerated gastric emptying. We have seen improved esophageal peristalsis, and it limits the lower esophageal sphincter relaxation and reduces esophageal pain perception. And the third step is to make sure the good bacteria are re-inoculated into that body. Usually the Lactobacillus reuteri and Bifidobacter species are important. Fourth step is to replace the gut enzymes. Like I said, low stomach acid leading to reduced digestion, contributing to reflux. So we need to first replace the enzymes when the person is not able to tolerate acid supplementation. So when a very good test to check if low stomach acid is the problem is to take a trial of apple cider vinegar in empty stomach. If you have symptoms aggravating, that means your stomach is not ideal position to supplement acid. You need to wait for the stomach to heal, and then we start supplementing acid. But if you feel better after apple cider vinegar, then that means you have reduced acid secretion, and you need to supplement with enzymes and acid. And if this is an initial test to make sure that you are eligible to take hydrochloric acid supplementation directly. But sometimes I've seen in patients with a lot of small intestinal fungal overgrowth, apple cider vinegar, because it's a fermented thing, can contribute or worsen the symptoms because it is fermented. But otherwise, it is usually well tolerated. Final step is to rebalance our body, reduce our sympathetic overreactivity. In our practice, we teach them pranayama, meditation, we do sound therapy, yoga, and emotional freedom technique. So the first patient, 32-year-old, what I did was initially we eliminated wheat and dairy, made it as simple as possible for her gut to digest, taught her emotional freedom technique, vagus nerve exercises, and did sound healing sessions to actually get rid of her childhood traumas and her stress, and then started supplementing with enzymes. We started giving her nutrition to improve her mucosal lining, like DGL licorice, methi seed extracts, L-glutamine powder, zinc carnosine, and magnesium. After 4 weeks, we started acid supplementation, but I didn't start tapering PPI because she was on double dose PPI. And then we started tapering PPI gradually. In 10 weeks, we could taper PPI, and she was completely asymptomatic. Another patient who's 75 years old, who came to me with actually for diabetes reversal, but he had severe acidity and gastritis. He was on PPI for 10 years, and he thought it's part of his lifestyle and he should be on these drugs for his life. And I made him understand that unless we reverse GERD, we cannot reverse your diabetes. And it took about 2 months for him with a almost similar kind of a protocol to get rid of PPIs and reverse his GERD and gastritis completely. And then after we did that, it only took about 1 month to get rid of all his diabetic medicines. Because once we reduce inflammation in the body starts healing itself. Thank you so much for giving me the opportunity to talk in this wonderful conference. I will just take 2 questions. Okay.
Yes.
Can I take questions, or is...
We'll take one question, sir. What can be the cause of constriction in throat when food has to be pushed down with water?
So it cannot be a single answer, because we need to look if it is a motility problem, is it an esophageal muscle problem, or is it the mucosa is inflamed because of the reflux. So we need to properly evaluate the entire picture and look at the root cause and then give an answer for that question.
Okay. So there are 2-3 more questions. I will request you to answer them in the chat directly.
Sure.
So thank you so much for sharing your insights. I'm sure our audience is better informed about GERD and the PPIs and what actually should be done if someone is experiencing GERD. Thank you so much for being with us.
Thank you so much.